Yeah, good morning, everyone. I'm also glad to see many of you here. I was just thinking, oh my God, as usual, a microbiologist will talk, only 4 people will listen. But the more you listen as surgeons, as treating doctors, I think there is more outcome oriented results in your practice. Okay, I'm not here to give you statistics, I'm not here to introduce you to bacteria, but I'm here to give you some kind of logic. I hope I'm known for not giving any kind of boredom lectures. I hope you enjoy through this conversation more than a lecture here. I was given the enemy and the warfare kind of a picture, so I thought, okay, let me just take that up. Anyway, there are so many army men there. There is a aeroplane here, and there is a sea missing with the naval forces. We have 3 different types of fighting antibiotics, but we have huge number of enemies. A single enemy can recur repeatedly and then irritate you, just the way the Indian constitution, India is going through. Now, without a culture, without understanding your enemy, I don't think it is appropriate to do the antibiotics. So let's understand. What did the art of war says? Know your enemy and know yourself. In 100 battles, probably you'll never be in a peril. So understand your enemy more through probably a microbiologist's point of view. Here it is. It's always ever changing. What you got in the last culture will never be the same in the next culture. You can scan through. When you will see a lot of anaerobes and fungi coming into the picture. Let's first accept it's not a single bacteria that's causing the infection. It's almost always polymicrobial. And always understand, when you have a patient of diabetes, foot ulcer, you're going in for a long battle. And prepare your ammunition accordingly. Don't use broad spectrum. All your ammunition you dry, you end up nowhere. Always look for these bacteria in the most difficult spaces, hidden in the wound, in the bone. And every type of microbe, you should be able to get it. The best is to go through stains. What you miss in culture, you will get them in stains. Ask for multiple gram stains, AFBs, fungal stains, KOH. Ask them to repeatedly do it. Somewhere you'll find your bacteria. Now, having all that, sit down. It takes time, yes, but it's worth the time spent. So we have antibiotics. That's our only weapon. Actually, it heals. It does great jobs, provided that's not the only weapon you choose. Like Armstrong was saying so beautifully, he put the culture in the 5th place. I really agree with him. Debride, flood, lavage, do everything. Then you take the culture and then sit down. Now, when we come to this, what is the technical advice I would like to give? I get a lot of reports on my mobile saying, check it once before we give. This is not microbiologists asking, it is the surgeons across Bangalore, probably Gujarat, Maharashtra, wherever I've given lecture, they send me the reports asking me, what's the next antibiotic? I say, first check whether the report is correct. This is my technical advice. Anytime you find a highly resistant gram-negative bacilli, if it is reported sensitive to ampicillin, think twice. If Stenotrophomonas is sensitive to carbapenem, think twice. Staph aureus resistant to vancomycin, think twice and ask for repeat. Strep pneumoniae is resistant to vancomycin and linezolid, think twice. Now we have cell envelope, protein synthesis, DNA synthesis. These are the systems in the bacteria on which our antibiotics attack. What is the big question here? When we report ESBL, I continue to report ESBL producer, and the consultant continues to put the antibiotic most forbidden, augmentin. Think twice. What is it? It's a very simple. Forget the mechanism. The first column is only for microbiologists or those who want to understand. The second column is yours. And the last column is when you have to prescribe. So if you have ampicillin, amoxicillin reported R, then definitely you have second, third generation cephalosporin. Sorry, yes, the antibiotic affected means R, okay? So monobactam, carbapenems are available, third generations are available. Now, ampicillin, amoxicillin gone, cephalosporin second, third generation gone, monobactam gone. Think twice. That's where we are standing on ESBL. Extended spectrum beta-lactamase doesn't allow you or give you permission to use the third generation cephalosporins. That's when you have carbapenems, yes, you have BLI. The beta-lactam inhibitors and the cefamycins, they're all still available. Now there is something called AMC. Later on you will see one more slide on AMC from me. When you have AMC reported, if they have not reported, ask for cefotetan, cefamycin, cefoxitin antibiotics on the sensitivity plate Kirby bar that we use. If MICs are given, you are good. Otherwise, look for on the Kirby bar method, cefoxitin, cefotetan and cefamycin. If there are, forget about your BLI. No Magnex, no sulbactam, no tazobactam. You are left with only carbapenems, probably fourth, fifth generation cephalosporins and tigecycline. Now go to the last, metallo-beta-lactamase. It's like a big blanket cover on all the antibiotics. Probably you are left with tigecycline, not sure, astronam in case of Pseudomonas, probably EDTA, probably all your other methods, and also prayer to the God. Probably that helps next to the bed. This is how chronicle your patient goes, and then expect this in your patients. Okay, now AMC, I said I'll have one more slide. When you have AMC, clavulanic, tazobactam, sulbactam is a big no. If they are not reporting, you yourself can look for, as I said, cefoxitin, cefotetan. When one of the consultants says it's not reported, I think talking to microbiologist helps, requesting her to put them helps. Probably she'll also understand or he'll also understand and learn with you. Whenever I have MRSA reporting, do you see the two reporting that I've given here, MSSA, MRSA? This is a typical picture of MRSA. It should not differ. You cannot have S2 cefotaxime and still call MRSA. You may not have any of these fluoroquinolones at all. If they've written S, think twice. And you still use any of these ciprofloxacin or levofloxacin on that MRSA, second day you will be again facing the same issue, resistance. Now, if this is not how the MRSA report goes, please sit down with your microbiologist. I put this slide in every conference because most of the microbiologists take the picture of this and go and mimic and then write it good. But then it means they also have done the same mistakes. Okay, now there are commandments in antibiotics. Very, very sweet commandments, just like the 10 commandments. If an isolate is an ESBL, never use penicillin, cephalosporins, but you can use third generation cephalosporin with BLI. If isolates are salmonella or shigella, never you think of anything but third generation cephalosporins. If isolate is MRSA, never use beta-lactam like penicillins, any of these BLIs, carbapenems, penems, and of course, no fluoroquinolones. If isolate is enterococcus, don't use cephalosporins, aminoglycosides, clindamycin, cotrimoxazole. These are all dictums. They have an inherent resistance to them. If an isolate is a listeria, never use cephalosporins. This is the commandment that we use. Thanks to Pfizer who gave me these commandments. The good question or the God question. Now, how do we interpret an MIC? These days, a lot of doctors do get MIC reports because the machines do produce. I have a way of it. I don't know, Subra will give you more of it. Subramanian Swaminathan is one of the ID specialists here. I told him I'll not encroach on that, his subject, but I'll give you some input on this. It's just the lowest number of the concentration that can kill the bacteria, right? Now there is a break point. Break point is where that's the highest limit it can go to. Now keep these two in mind. If you are done with this slide, there's a bit of theory. I don't like to read the theories, but I would like to tell you, you cannot compare it with antibiotic disc or anything else. It is, or the choice of antibiotic is always based on the MIC, which is lowest. Breakpoint must be understood, and comparing MICs of two different antibiotics of your choice will give you an insight on which antibiotic I use. So my last 10 minutes, I would like to delve on this, especially an example of, this is a case presented, I'm taking it as an example here. It's a E. coli. Now you can see 0.25 to 16 is what MIC sensitivity given. Okay. Now for amoxicillin it is up to 16, breakpoint is 32. Breakpoint is where the last point where in which you can use it. Now look at 0.25 of the amoxicillin. Remember this slide. Second one is, it's also tested for cephalexin. Remember the sensitivity stands at 2. The breakpoint is again 32. Okay. Remember 0.25 of cephalexin, 2 of cephalexin and 0.25 of amoxicillin, 32 breakpoint. Let's see how this goes. Now the amoxicillin at 2 microgram ml is the dilution. How many dilutions away? It is 5 dilutions away from the breakpoint. You see that 0.25 and 32. It's farther away from the breakpoint. Now 2 and 32 are only 3 boxes away from 32. Remember that. Now here the MIC is 8 microgram, is 2 dilutions away from the breakpoint. If you look at it, 8 is just 2. Now you have to understand, the farther it is or 4 points below the breakpoint, the better drug it becomes. So between the two, I would prefer an amoxicillin to a cephalexin. Did you understand here the breakpoints? The MICs, the lowest farther away from the breakpoint is what is preferred in your analysis. This is not how you get your report. Now in your report it appears amoxicillin, clavulanic acid, sensitive, 2, 8.22, yes, 32. 32 breakpoint. Sensitivity is 0.2 and 2 is what you should be looking at. 2 is closer to 32 or 0.2 is closer to 32. This is how we expect you to understand. 2 and 8 are the numbers of MIC. 2 is 4 times behind 32 breakpoint, while 8 is just 2 times behind the 32 breakpoint. I would prefer amoxicillin, clavulanic acid to my patient rather than cephalexin. Now tips of MIC. It's very simplified. For staphylococcus, you ask for vancomycin MIC, more important than any other antibiotic. It can help actually a physician if he is in duvidha to choose the best of the antibiotic. How? Now a regular sensitivity report will be RS or I. I don't put I because I always prefer R and S. Intermediary will come and help you if there is an MIC value, but I stick my reports to S and R. Now here ceftazidime, ciprofloxacin, third generation, cephalosporin, fluoroquinolone, we have an aminoglycoside, we have imipenem, piperacillin, tobramycin. Now only ciprofloxacin is R. Just remember, Ciplox was R. Repetition, am I going? Okay. Do you see any difference between gentamicin, tobramycin? Both are SS here. Genta is S, Tobra is S. You don't see much difference. Now do you put Genta or Tobra? Let's see. I am marking Genta and Tobra as which one to choose if this is my drug of choice. Let's see the MIC. Here is where I think MIC will help you. Gentamicin stands at 4. There's no breakpoint here. There's no breakpoint here. Tobramycin stands at 0.5. Now you give me an answer. If there is a breakpoint 32, what would you use? Obviously. So this is how you compare the two antibiotics. If you have MIC, go for the lowest. If you have a comparative, go for the lowest from the breakpoint. Good. Win-win situation for me, because I tried my best to give it to many consultants. I don't think they understood. Finally somebody said tobramycin. I'm so happy. See, why we did this is gentamicin is 8 times higher in its MIC and tobramycin is on the borderline between susceptible and intermediate. So, what's the take home message? Am I finishing it too early? Then I can take some questions. Okay. Diabetic ulcers, always polymicrobial. Investigate thoroughly and have an open mind, no bias. If I have given to somebody, my consultants are mostly neurosurgeons, foot surgeons, general surgeons, plastic surgeons, MBBS, and sometimes even Ayurvedic. When I give candida in a gram stain, I don't culture. I wouldn't have gotten it in my culture, but I have put it in gram stain, budding yeast cell seen. They say, from somewhere you bring it, yeah. Where will I bring candida in my stain? It's generated by probably inappropriate antibiotic usage or long-term antibiotic usage. When I point out a candida in the absence or presence of many other antibiotics, I think there's a message. Either you use, of course, anti-candida, or you are abusing antibiotics and creating monsters. I think narrow your spectrum. Go also and hit out at candida because it can be a menace eventually. And include a clinical microbiologist. I'll tell you why. My affair with DU has been from internship days where we used to just pour hydroperoxide, water, betadine, some ointment which our surgeon gave, send them. I never thought those ulcers will heal in our lives. But when I was exposed to the fineness of foot surgeons, the plastic surgeons who would do plastic surgery and skin grafting, it opened. I was like, okay, let me see what all bacteria are there. So one day, for my own interest, I took many bacteria. I charged patient only for one, my own lab, so it gave me that liberty. But when I did, I isolated so many bacteria. And I think that's up for panel discussion today. Please attend. The kind of bacteria, the kind of work we did on that day, it opened the eyes of the surgeon and also me. And we did the graft after taking care of it. Graft took on very well. I think Dr. Subra will come to that on that. Always be focused on the antibiotic. Never do broad spectrum. I never appreciate even BLI being used. Try to put it as narrow as possible. Make it very short. And always think of other vascular problems. Always don't think it's infection. It can be more than one. If you are not sure about MIC, seek help. Otherwise, compare the breakpoints and also the MIC and take the choice. There is a take-home message with a lot of suitcases. It's a win-win situation for infection in DU if at all we have a strategy, not a bias. And I can see a lot of patient hearing, and thanks Podocon for this opportunity to present my case.